Hello everyone. My name is Brittany. I work with slpmaterialgirl.com. I'm a licensed speech language pathologist and I'm also certified clinically competent with ASHA board. And I'm here to talk about a comparison of autism spectrum disorder and ADHD. Before we begin, I want to give a little disclaimer. The following presentation was generated during my graduate study research and by using my own clinical expertise. Please post a comment below if you agree or disagree with anything I discussed today. I'm a lifelong learner, so if anybody listening has experience with working with students with autism spectrum disorder or ADHD, or have it themselves and want to, just comment or start a discussion, I would love to read your comments and hopefully respond to them as well. And note, the intention of this video is not to provide therapeutic intervention. I am not providing medical advice or treatment, and SLPs, clinicians, whoever's listening to this, are to use any information I provide at their own risk or discretion. So let's begin by talking about some commonalities between autism and ADHD. By the way, I will probably throughout this presentation use ASD and autism interchangeably, but I am talking about autism spectrum disorder when I say that. So shared symptomology of ASD and ADHD. This is a little confusing how I wrote it, but basically what it's saying is children with ADHD show symptoms of autism, and children with autism show symptoms of ADHD with a greater frequency than the general population. So this makes diagnosing and treating ADHD and ASD complicated. Not that SLPs diagnose autism spectrum disorder or ADHD, but they do treat it in the schools every day and in the clinics and etc. But that's just a commonality that they share, that they have shared symptoms. We'll talk more about that in a minute. This slide right here is just reiterating what this slide said. A couple researchers and research groups talk about the percentage of individuals with one of the disorders that display symptoms of the other disorder. So this group here says that between 59 and 83% of individuals with autism spectrum disorder display symptoms of ADHD. This researcher group right here says about 50% of people with autism have symptoms of ADHD. So it's just saying that it's a high percentage. Vice versa over here, children with ADHD who have autism, symptoms common in autism, 65 to 80%, 66, 20 to 50. It's pretty high. And I'm sure people see this, all the time in their practice, in their daily life. I'm sure one of us has said, a lot of us have said to ourselves, oh, that student has ADHD, because I see a lot of symptoms of autism. Not that we're diagnosing them, but you're entitled to your thoughts in your head. And I know I have said that to myself. But as I want to talk about in this presentation, things, they may clinically manifest different than the cookie cutter definition, by the DSM-5, like what it says someone with autism looks like. If you've met one person with autism, you've met one person with autism. Everybody clinically manifests different. Everybody's an individual. They're going to present differently. They may have autism and present with ADHD symptoms. And there's a reason for that confusion that I hope I can illuminate a little bit further in this presentation. But we all, the cause, they may end up with the same effect, but the cause might be different. And I'll talk more about that in a minute. I don't want to get ahead of myself. Okay, so just exploring commonalities. Common areas of similarities in autism and ADHD include difficulty with multiple areas of executive functioning. Some believe that that actually is the core cause of both autism and ADHD, this executive functioning difficulties in these areas. Highlighted on this Venn diagram, you'll see in the middle, both of these disorders demonstrate difficulties in social communication, working memory, self-monitoring, fluency, concept formation, and attention. It gets kind of, that's really interesting, but on the sides here, they're the opposite. So autism, severe difficulties with cognitive flexibility and planning, but somewhat more preserved inhibitory control. While ADHD has severe difficulties with that inhibitory control, but somewhat more preserved skills in cognitive flexibility and planning. And I've seen this firsthand. I've had a little girl who was positively diagnosed with autism spectrum disorder, and her cognitive flexibility, in her case, was impaired, and her planning, her flexible planning. If we started a book, she would want to start the book, read the book, and finish the book, start to finish, left to right. And if something interrupted that schedule that I had laid out, she would have trouble regulating her emotion around that. And she would have trouble taking herself away from that task because she was very schedule oriented in order to help her regulate. While in that same classroom, it was a cross-cat room, I had another student that was positively diagnosed with ADHD, and he would jump from task to task to task, very flexible, as long as the activity was like cognitively stimulating and interesting. He could jump from task to task to task. Now, let's say there was a task he very much enjoyed. Let's say we were, playing a ball game, like we were throwing a ball around and naming facts or something, just an example. And that was really stimulating. It would be hard to pull him away from that activity because that was really cognitively stimulating, but reading time wasn't for him. So he did have that flexibility issue at that point. So like I said, if you've met one person with ADHD, you've met one person with ADHD. Everybody is different. All right, so shared sensory and motor deficits between the two disorders. About 50% of children with ADHD have sensory processing difficulties. About 90% of children with autism have those sensory processing difficulties. So all this input, they can be overstimulated, is what this is saying. I don't know if the listener, has encountered a child where if there is a movie on with flashing lights and lots of sound and explosions, and there's also other things going on in the room, it can be too much. It can be very overwhelming. The music is very loud and pounding and drums, and all this sensory input can lead to dysregulation of behaviors and emotions. So this is saying 50 and 90. They both have that issue in some cases. Motor processing difficulties. So that's fine motor, gross motor. About 50% of individuals with ADHD and about 70% with autism spectrum disorder. Both individuals with both disorders may have difficulties with self-care, autonomy, and adaptive behaviors such as, ignoring dangers, repetitive behaviors, practical skills, self-direction. They both might have difficulty in those areas. And they also have shared communication deficits. So here we come in as speech therapists. They both have similar early language development profiles, language delays, language impairments. So this is interesting. As a speech therapist, I am not going to treat autism spectrum disorder. I am not going to treat ADHD. I am going to treat language delays or disorders in an individual who has autism spectrum disorder or who has ADHD. It seems like a fine distinction, but it's really important. You look at this individual holistically. you say Johnny has pragmatic language, you know, difficulties. Johnny may have this is speech, but articulation disorders. Johnny may have, difficulty with problem solving. He is an individual. Those are his three problems. Then I also have Sally, who also has autism. And Sally, her only difficulty is, let's say, social skills, pragmatic language issues. You treat within your purview how the student is presenting, how they, what disorders are clinically manifesting. You do not say, you don't write a goal saying, I'm going to treat this, treat their autism spectrum disorder. No, I'm going to treat their, pragmatic language disorder. Because you can also have a student that doesn't have ASD that has a pragmatic language goal. I mean, I think that's actually kind of rare, but it's not impossible. I mean, you have to look at everyone as an individual. Whether they have an expressive or a receptive language goal, it's specific to them. Okay. So I actually, when I'm writing goals for a student and I've, tested them and informally and formally, I do like to find out if they've been positively identified as autism spectrum disorder or ADHD, but it's not necessary. You're going to see where they differ from the neurotypical individual, and you're going to write goals based on that. So it's honestly not necessary. But being informed about these disorders does help you make, sound clinical decisions. I think it's just the more you know, and we'll get into that a little bit more later as well. It's also meaningful for like being a part of the team, but I digress. Shared communication deficits. Children with ADHD have pragmatic language difficulties similar to children with autism, and many individuals with ADHD may experience social communication impairments that are consistent with those in autism spectrum disorder. So here's what I was talking about, that you start at the beginning of the different roads, but you end up in the same place. I've got a chart. So we're on slide 44. I'm going to go down to slide 50. I like this slide. Okay, so let's say this is the student with autism spectrum disorder, and this is the student who has ADHD. They started on different roads. These are distinct, separate disorders, but they end up in the same place. Down here is pragmatic language difficulties or social skill difficulties. Why might that happen? Well, in the student with autism spectrum disorder, let's say, I'm just going to call him Johnny. Johnny is talking to Sally, and Johnny is not picking up on her social cues. Sally is giving every indication that this conversation is either over or it makes her uncomfortable. Let's say they're talking about something serious like religion. And Johnny keeps talking about this topic, and he's very interested in it. He knows a lot about it. Maybe he practices whatever religion they're talking about, or he's looked it up or studied it. And he's going on, and Sally is giving all these cues that she does not want to have this conversation. It's either making her uncomfortable, or it's different from her own beliefs and she's trying to maintain peace. Maybe she has her arms crossed. Maybe she's not commenting back. She's just making like non-committal head nods, like nodding now and again. Maybe she even has one foot out the door. She's holding the door open. She's got one foot out. And Johnny does not see that she's basically running away from him. Like, she's trying to end this conversation, and he's not picking up on it. So that would be a social skill difficulty. Ronnie over here has ADHD. Ronnie's also talking to Sally. Ronnie is talking about religion because it is so stimulating to talk about this. He is so interested. Let's say he's talking about the Greek gods. I know I was really interested in that when I was younger. And he's talking about them, and he's fascinated, and he's going on and on because he's just fascinated by this subject matter, and he's very focused on it. It's very it's very stimulating for him to talk about these Greek gods. And Sally, she's giving him every cue that I don't really want to talk about this, or I have to go, or this is not interesting to me. And it's not that Ronnie can't pick up on her social cues. That's not a difficulty that this imaginary person has that has ADHD. It's that he's not picking up on them because he is so hyper focused in what he is interested in. So you see how they end up being the same. They both ignore the social cues, but they started on different roads. So I think that's why I think that's why it's good to be informed about autism and ADHD. It's good for you to have as much knowledge as possible so that, I mean, you're just going to treat it how it is, but you can approach it differently. You're going to approach it differently with Johnny and Ronnie. You're definitely going to be showing Johnny more of like the different cues that he was missing. And then with Ronnie, I would say, well, in both cases, but it's different. I'm not here to give treatment. I'm here to hopefully tell you something new about autism spectrum disorder and ADHD. I would really want to think about what I would want to do with Ronnie in this case. But anyway, I digress. Let's go back to slide 44. Comorbid conditions. Both of these disorders put individuals at a risk for anxiety, tic disorders, trichotillomania, depression. I hope I pronounced that right. Puts individuals at risk for these comorbid conditions. This is just a little illustration, the cycle of depression, tic disorders, what they are. This is trichotillomania and depression in children because it can look different than adults. You want to treat these co-occurring conditions because they can lessening the severity of those symptoms can positively impact the individual and improve their prognosis. If they are struggling with depression and anxiety, it's going to make the whole condition worse and harder to treat. You're going to be fighting, two monsters instead of one. Not to say, I don't like how I just worded that. Not to say that autism or ADHD is a monster. People with these disorders are individuals, and they can really embrace what makes them unique to them, uniquely beautiful and unique. It's really like I said with the social communication issues, that's really the monster is they want that friend. They want to talk to Sally. They want to be Sally's friend in this scenario. And they don't understand, like let's say someone with autism doesn't understand why Sally didn't come back to have another discussion with them. Well, I want to make that person aware Sally sees things a little different than you do. And how can we make connected comments, be more mindful of social cues so that we can keep our communication partners engaged and build meaningful relationships. That's what I meant by monster. So please, I hope I didn't offend anybody because that's not what I meant. All right. Risk factors for autism and ADHD. Nutritional differences, gender, premature birth, maternal wellness factor. These are just risk factors, not causes. They're risk factors. So decreased omega-3s, being a boy, being born premature, if your mother smokes or has diabetes. These are all risk factors that increase the likelihood of someone having a positive diagnosis for ASD or ADHD. Similar causes, extensive brain network connectivity abnormalities, so throughout the brain, and partly similar familial genetic factors. I might do a separate video, excuse me, on the causes of autism and ADHD. I'm not going to get too much into it in this presentation, but just talking about the commonalities, similar. Differences. Okay, so despite all of the overlap in clinical presentation we've just been talking about, they are defined as distinct disorders. And 3 distinct differences I'm going to talk about are age of onset, treatment effectiveness, and differing specific executive functioning deficits. Okay. Okay, we already kind of talked about this, starting at the different road. And this is actually those executive functioning deficits that are similar, and these are different. And we already spoke about that. Oh, did I not get into it? You know what? I think I talk about treatment and age of onset a little later in the presentation. Okay, so implications for treatment. Autism and ADHD are common disorders. They're considered major public health issues. Children with neurodevelopment disorders such as autism and ADHD highly benefit from early intervention. In clinical practice, symptom descriptions of both disorders may become entangled, obviously. And the overlap in symptoms complicates differential diagnosis. It's common for children with autism to first be mistakenly diagnosed with ADHD. So that's interesting. Close to 20% according to this group here in 2020. There are established evidence-based practice treatment methods for both autism and ADHD, and they also vary across a lifespan. So student versus adult, or student versus high school, or elementary versus high school. So in childhood, the focus of autism treatment is to improve adaptive abilities, social skills, and academic skills. And then into adulthood, the focus shifts to adaptive daily living skills and developing vocational skills. So setting these kids up for success in the future, which honestly we should be doing with all the students. Developing those, not everybody. I mean, some children are not ready to really, yes, teaching skills that will help them succeed in any field that they apply themselves to. I'm going to stick with my original statement. Treatment for ADHD. For children, the focus of the treatment is parent, guardian, teacher training in behavioral modification and organizational interventions. So these are just like the main focus of treatment. However, like I was saying with, I believe I called him Ronnie, if he has social skills or pragmatic language issues, I would absolutely address those as well. But anyway, so this, you are only with the student for, 30 minutes, 45 minutes, maybe an hour. So you need to train the guardians and the teachers on contingency management so that they can carry over what you're teaching and really make a significant impact in the child's life. You being with them 2 times a week for 45 minutes or 3 times a week, whatever it is, whatever you set as their frequency, is not as impactful as a parent who carries over those skills. I also have, with organizational intervention, so this picture is great. So you create checklists, charts, you use timers. She's in a nice quiet room where she can focus on her work, establish routines, use planners, set alarms. These are all great tools to keep her focused and able to manage her ADHD. So that's a great picture for behavioral strategies. And then in adulthood, the focus shifts primarily to cognitive behavioral treatment. So drugs are often used. Well, I don't know how often, but I've seen them often used in the treatment of ADHD very effectively, and that can be throughout the lifespan. However, drugs are not used typically with individuals with autism spectrum disorder. Um, drugs do not treat autism spectrum disorder, to my understanding. I may be wrong. If you are a doctor or a psychiatrist or psychologist or somebody who dabbles in this, and you have a different opinion, please comment below. But it's used for ADHD and not for autism. So that's interesting. That's why they're completely separate. I mean, that's not the only reason but if they were like the same thing, like from the same tree, they didn't start at different roads. They actually started at the same root. Then why would drugs be effective in one case and not the other? And actually, in individuals who have both combined ASD and ADHD, they will respond poorly to traditional ADHD treatment and have increased side effects from the medication. So when you have individuals that do have both, you'll do non-pharmacological methods such as psychotherapy, individual and family, social skill treatment, and behavioral intervention. I love these little first then schedules. These are really great with with a lot of students. These little first then schedules really keep children focused. They're great. You can print out a bunch of activity pictures, laminate them, and then put Velcro, and then you just slap the different, what you want to do first, and then when the child is getting off task, you just point, first we do this, then we do this, and those words are pretty concrete. I think this is a great little scheduler for behavioral intervention. I was talking about earlier about 20% of children with autism get first misdiagnosed with ADHD. So what are those implications? Diagnosing someone with ADHD might delay the diagnosis of autism spectrum disorder. And it's interesting. Both of these are typically diagnosed on the basis of parent interview and clinical observation, which lends to the possibility of human error. Like I said, if both of these individuals are displaying pragmatic language issues, or someone with ADHD is displaying pragmatic language issues, you may think they have autism, or vice versa. If it's an individual that has autism spectrum disorder and they're displaying ADHD symptoms, because remember, it's a large percentage, like somewhere between 30 and 50%, as high as 60, 70, 80%. I mean, the numbers were all across the board if you were with me at the beginning. But if you have someone with autism spectrum disorder displaying ADHD symptoms, which is really common, it's going to mess up their diagnosis, and they're not going to respond to those ADHD drugs you're giving them. So it's really important to view the individual, really deep dive if you're in that practice that can diagnose those disorders. Overall, results of the literature review suggest that accurate diagnosis is paramount, because, like I said, those drugs don't work with the autism spectrum disorder individuals. However, we can still treat them as speech-language pathologists. We can, and if you're viewing people holistically, and I would say that the professions can, like the OT, possibly the PT, the psychologist, you can still treat them if you view their symptoms and don't just label them and treat them like that label. Don't just have your ASD handbook and that's all you're going to use. You have to look at these people as individuals. Differential diagnosis is difficult due to that shared symptomology, and doctors and clinicians must consider the presence of comorbidity, but not mistakenly assign it. So consider, okay, I'm seeing ADHD symptoms here, but is it comorbid, or are they just displaying the symptoms? So, an individual, I've been hammering about this all the time. Their symptoms may be a result of environmental influences and not neurobiologically based. So I knew of a student that's his mother kept him very close. He rarely interacted with other children of his own age or just period. And he came to, I believe he was supposed to be put in, I don't know if they put him in kindergarten or first grade when he came in. He was 7. But he presented like a classic severe, a person with severe autism spectrum disorder. That's how he presented. However, this kid never had the chance to interact with other children. He just interacted with his mother. And we didn't know if, his manifestation, if it was a result of environmental influences or if it was neurobiologically based. Like, if he was raised in a more typical, or I'm going to say a healthy environment, would he still have presented like he presented? By the way, I'm not saying that environmental influences cause autism. Like if you do live a little more of a sheltered life, for all I know, you live in the middle of the country and you're living in the woods. I'm not saying that, because mom or dad or grandma or whoever's living with you can definitely provide a rich and social environment with you, and they can take you places, and they can teach you. So I'm not saying that. This was a really specific case. And I mean, I grew up in Austinburg in Ohio, which is in Ashtabula County, pretty secluded. We had a couple neighbors, but nobody my age, and I feel like I'm within within functional limits as far as my social abilities go. I did attend a public school, so I don't know if that's a good comparison, but at age 5, let's say I was pretty typical and I was a little more isolated. So that's not at all what I'm saying. I'm saying, though, that sometimes the environment can play a factor, influence things that cause misdiagnosis. I think that collaboration among professionals is imperative for input, diagnostic labeling, and that's why you want to be as informed as possible as an SLP about these 2 disorders, so that you can meaningfully contribute to the conversation in a safe space. You're not going to be the one that makes that call, but you can meaningfully add to the conversation. Treatment in relation to our profession. Like I said, SLPs do not diagnose it, but they do play a major role in treatment and management of the disorders. Treatment in relation to speech pathology. Thorough understanding is important of the underpinnings. Why? So that you can gain greater insight into why behaviors manifest, design more effective, evidence-based treatment plans, and provide valuable input when collaborating with the medical teams and the school treatment teams. Oh, and that's it. So hopefully you're here with me still. If you were interested in this, on my site, I actually posted the paper I had written in my blog. So if you feel like reading it, I cite all my sources. Right now I'm going to be posting this video on YouTube. So like I said, comment below, like the video if you liked it, subscribe if you want to see more from me. Go to slpmaterialgirl.com if you're interested in looking at some of the materials I have for sale. I'm adding more materials each week, so there'll be more school-aged materials available, and then there should be some adult materials coming pretty soon as well. I do have experience in the assisted living, but working with adults in the clinic as well. So thank you so much. I hope you enjoyed this presentation, and I hope you have a great rest of your day.